Good evening. First of all, for this live with Professor Tanaka, I would like to introduce two videos, institutional videos of our sponsors.
Transformar grandes ideias em grandes
Transforming great ideas in
realizações.
great
Servir
accomplishments.
milhões de famílias todos os dias. Colocar as pessoas em primeiro lugar. Nós transformamos o desafio da maioria das empresas em nosso DNA, em nosso propósito. Cuidar de pessoas. Para nós, cuidar das pessoas faz parte da nossa rotina e é o motivo de nossa existência. Cuidando dos pacientes, nos propomos a oferecer o melhor em medicamentos hoje e sempre. Cuidando de nossos colaboradores e de suas famílias, alimentamos a garra que forma a nossa nação azul. Cuidando da nossa comunidade, oferecemos ferramentas para juntos transformarmos o mundo em um lugar melhor. O cuidado faz parte de quem somos, faz parte da nossa missão. Apsen Farmacêutica, o cuidado que transforma.
Para toda pergunta, imagine o conhecimento. Para toda busca, imagine uma inovação. Para todo mal, imagine a cura. Para você imaginar, a INGLêS realiza pesquisas inovadoras, investe em tecnologia e desenvolve novos medicamentos que cuidam da sua saúde. Porque quando o mundo está paralisado pelas dúvidas, alguém precisa imaginar as respostas. Medicamentos INGLêS. Sua saúde merece.
I'd like to thank for the support of the Brazilian endoscopy, digestive endoscopy on behalf of Jário Silva and the Inter-American Endoscopy, Digestive Endoscopy Society in Asador. We're going to start our lesson today with the presentation of our two moderators, Eduardo Moraes. Good evening and thank you. It's a great pleasure to be here participating in this lesson with Professor Tanaka. I am a clinical oncologist from the Bahia Oncoclinics and so especially interested in gastrointestinal tumors. So it's a great pleasure to discuss a theme that oncologists have already been part with diagnosis and treatment of the early colorectal cancer. Now I yield the floor to Dr. Vitor Rossi, the endoscopist of Memorial Hospital and member of SOBED. Good evening, everyone. It's a great pleasure to be here representing the Itaigara Memorial Hospital and participating in this event, a lesson in the new normal mode that we are learning little by little. And it's very interesting to have the opportunity to have Dr. Tanaka in this brilliant lesson we are going to have, no doubt. And we'll follow now to start the lesson in on right time. Thank Professor Tanaka hugely for having allowed us to have a live in Brazil, Latin America, and some countries in the world. Professor Tanaka is a PhD and professor of the Department of Endoscopy of the University Hospital of Hiroshima in Japan. One of the world references in diagnosis and treatment of colorectal cancer. And he has participated effectively in the creation of the classification of JNET. The dynamics of this lesson will be divided into 4 parts. The lesson itself, Professor Tanaka is going to present images that are going to be discussed through a quiz, questions that have been sent previously to the professor, and he's going to answer at the end of the lesson, and questions that are going to come from the audience through chat. Dr. Tanaka, you're so welcome, and it's a great honor to have you among us.
Thank you so much. First of all, it is a great honor for me to be able to give a lecture in this webinar. I greatly appreciate Dr. Rodrigo Felipe for inviting me to this webinar. I'm very worried about the Brazil in COVID-19 problem. Everyone, please take care and do be safe. Today, I'd like to deepen your understanding of colorectal NBI magnification, especially JNET classification, and do my explanations and concrete case studies with the goal of using it correctly in clinical daily practice. So, so I will start my lecture. There are several enhanced endoscopy, image enhanced endoscopy, IEE technology. Today, I focused on NBI. This is a polyp. This is indigo carmine dye spring view. You can see tubular pit patterns. This is NBI magnifying view. You can see pit-like structure similar to this true pit. This true pit is, can you see allow? My allow? Can you
Yes,
see
Professor.
my...
Yes, yes, we can see the arrow.
Okay, so this true pit is corresponds to this line, this dark line, but this pit-like structure is thicker than true pit. The pit-like structure, or we call white zone, consists of a crypt opening, CO, and a marginal crypt epithelium, MCE. Colorectal tumors often show polypoid appearance, and the glandular meanders in a complicated manner. It is difficult to adjust the light for NBI observation to perpendicularly illuminate a pit. Therefore, usually an observation of actual pit as dark color is difficult. The structure with CO and MCE appears white and is observed as a pit-like structure in many cases. In 2011, we reached a consensus that we named this pit-like pattern as surface pattern. We organized the Japan NBI expert team in 2011. Professor Kudo, Professor Sano, me, there are many special magnifying colonoscopists in Japan. JNET classification was introduced in digestive endoscopy in 2016. If you are interested, please refer. This is JNET classification. This is basically modification of NICE classification. Key point is we estimate NBI magnifying findings, 2 items, vessel pattern and surface pattern, both very important. Type 1, Type 2A, Type 2B, Type 3. Please understand this classification. But even if you understand the concept, to use this correctly in daily practice, case discussion is very important. So later I will show you concrete many cases. I will explain the characteristics of each typing. Type 1, vessel is invisible, and the surface pattern, regular dark or white spot. similar to surrounding normal mucosa. This is very important. I will show you concrete cases later. Type 1 is indicator for hyperplastic polyp or SSAP, sessile serrated lesion. JNet type 1 corresponds to nice type 1. JNet type 3 corresponds to nice type 3. Vessel pattern is interruption of thick vessels, loose vessels, sometimes scattering of vessels. And the surface pattern is amorphous. In pit pattern diagnosis, 5N, non-structure. Type 3 is deep invasive cancer. Type 2 divided into type 2A and type 2B. Very easy to understand. In type 2A, vessel pattern and the surface pattern, both in brief, regular carrier bar vessel, regular distribution of vessel. Surface pattern also tubular, branched, papilla, anyway, regular. You can see pit-like structure seems regular. Margin of pit-like structure is very regular. On the other hand, type 2B, vessel pattern, surface pattern, both irregular. Irregular, very easy to understand. Type 2B shows variable caliber vessels, irregular distribution, and the surface pattern shows irregular or obscure, like this. If you compare these two slides, you can understand the difference between type 2A and type 2B. This is typical type 1 image. Dark dot, white dot, no vessel. This is hyperplasia or SSAP. This is a typical type 2A image. Regular pit-like structure. Please see the margin of pit-like structure, very smooth. This is typical image of type 2B. Vessels and pit-like structures are very irregular. This is typical type 3. Non-structure surface pattern and avascular area, and disrupted vessel and scattering vessel. Please see this slide, type 1, type 2A, type 2B, type 3. You can understand this definition. My colleague estimated the clinical significance of JNet classification. Using consecutive many cases of hyperplasia, SSAP, low-grade dysplasia, high-grade dysplasia, and early cancer, we clarify the significance of each JNet classification typing. As shown in this slide, type 1 is good, very good indicator for hyperplasia or SSAP. Type 3 is very good indicator for SM deep cancer. Type 2A. Type A contains low-grade, mainly low-grade dysplasia. But there's high-grade dysplasia. Several SM shallow invasive cancer, but mainly indicator for intramucosal neoplasia. Only 1%. SM cancer is only 1%. But type 2B contains various type of lesion from low-grade dysplasia to deep invasive carcinoma. By the way, some doctors estimate by NBI magnification only vessel findings, but we had clarified that NBI diagnosis by vessel findings alone is difficult. Then co-estimation with surface pattern is essential. For example, please see this slide. This is villus adenoma. Vessel pattern is very irregular distribution, and there are dense type. This is very irregular running. But if we focus on surface pattern, you can see very smooth margin, tubulovilus pit-like pattern. So even if vessel pattern is irregular, we can diagnose this lesion is villus adenoma by surface pattern. When we use JNet classification, we estimate both vessel pattern and surface pattern to diagnose JNet typing. Vessel pattern and surface pattern is not both and slash or. So this region we can diagnose regular vessel, regular surface pattern, even if vessels are irregular. Also, to observe surface pattern in NBI magnification, set up of structure enhancement of system is very, very, very important. This is same part of the same region in various structure enhancement setting. A8 is best, very fine picture. This shows beautiful surface pattern. But if you use structure enhancement A3, you cannot see surface pattern correctly. So to do NBI magnification, please reconfirm the structure enhancement in your system. So, in short summary, when we detect the lesion, we should do NBI magnification. So we diagnose JNet classification. If lesion is type 1, mainly hyperplasia, so follow-up is okay. But SSAP needs removal in some cases. For example, more than 10 millimeter or accompanied by cytological dysplasia. JNet type 2A can be treated endoscopic treatment because type 2A contains mainly intramucosal lesion. Lesion type 3 should go to surgery because deep invasive carcinoma. But type 2B, as for type 2B, this typing contains various type of lesion from adenoma to SM deep invasive carcinoma. We cannot select adequate treatment method only by NBI magnification. So for type 2B lesions, it is necessary to do pit pattern diagnosis with crystal violet staining. Of course, fluoroscopy or EUS are useful. So from now, daily practice, chance to use indigo carmine dye spraying will decrease. But when you want to determine the gross appearance, such as 2C, 2A plus 2C, LST, NG, pseudo D plus type, indigo carmine dye spraying is essential. To master diagnosis, understanding the principle and the definition is very important. However, if you can learn special lecture many times, if you don't do concrete case study, maybe you can use genetic classification correctly in daily clinical practice. Case study with good cases and face-to-face discussion with good instruction, if possible, including pathologist, very important. I will show several cases. How do you diagnose? This is typical hyperplasia, no vessel, same structure with surrounding mucosa. This is typical hyperplasia. So, how do you diagnose this lesion? This. Some novice diagnose this lesion as adenoma because there is a vascular pattern. However, this is a honeycomb-like vessel pattern, unusual for adenomatous lesion. Also, you can see dark dot like this. This is a hyperplastic polyp. Please see this slide. This lesion accompanied by honeycomb-like vessel pattern. However, surrounding mucosa also accompanied by same honeycomb vessel pattern. Even if normal chronic mucosa, if there is a mild inflammation, honeycomb vessel pattern like this occurs. So we have to subtract vessel pattern of surrounding mucosa from the lesion. This is GNet type 1. So this is histology of this lesion. This is hyperplastic polyp. However, this lesion accompanied inflammation and a little desmoplasia in mucosa. This is typical adenomatous lesion. Please remember this picture. This is typical type 2A, regular pit-like pattern. Pit-like pattern shows smooth margin. You can see regular pit-like pattern as 3L pit pattern in indigo carmine dye spraying magnification. Please remember this regular structure. It is necessary to compare irregular pattern later. This is typical adenoma. Also, this is flat lesion. How do you diagnose? Vessel pattern and surface pattern are both a little irregular. So we diagnose this pattern type 2B, GNet type 2B. This is ESD specimen, insular mucosal carcinoma. What do you think of this lesion? Tiny, less than 1 centimeter in diameter, flat lesion. This is NBI magnifying view. This view is not the best because observation is oblique. For NBI magnification, perpendicular observation is very, very important. Oblique observation is sometimes leads incorrect diagnosis. This is perpendicular observation. You can see disrupt of vessels and scattering of the vessels and non-structure amorphous. So this image shows typical JNet type 3. So we diagnose this region deep invasive carcinoma. To tell the truth, we noticed prior to NBI magnification mucosal ridging of this region. So at this point, we suspect this region is MP cancer, T2 cancer. So we send this patient to surgery. This region shows invasion into muscular layer. How about this? 3 centimeter flat elevated lesion. Some doctor conduct ESD without detailed examination, but we conduct detailed examination. Indigo carmine dye spraying view shows a regular surface structure. So we do NBI magnification, JNet type 2B. So we add EUS. Muscular layer is swelling, so we suspect this region is T2 cancer. So we confirmed by fluoroscopy. Like this, linear rigidity of deformity of lateral view. So we can get definite diagnosis of T2 cancer of this region. So we send this region patient to surgery. Like this region invaded into mucosal layer. Magnifying observation is only diagnosis of surface microstructure. So when we diagnose deep invasive carcinoma, we have to distinguish between SM cancer or MP cancer. In such a case, EUS or fluoroscopy is very useful. So let's start case study. Case 1. This is tiny sessile polypoid region. This is hyperplasia. How do you diagnose this region? I cannot see audience answer, but irregular surface pattern.
We're going to vote now, sir.
Okay.
If you, okay.
Please vote. Can I see
Can
answer?
we? Yeah, can we?
Please show me answer. Please show me result. Half doctor can diagnose correctly. This is type 2B. Type 3. Type 3. Type 3 is semi-correct answer. Anyway, never type 2A. This is EM. We conducted EMR. This is SM invasive carcinoma. Case 2. This is a tiny polypoid lesion. How diagnose this NBI finding? Please vote. Please vote. Please vote. Please show me result. Type 2A, half and half. Please see this slide again. Vessel pattern and surface pattern is not regular, completely different from the one I showed previously. This is JNet type 2B. So we conducted EMR. This is SM deep carcinoma. When we diagnose the lesion carcinoma, we have to do EMR or ESD. We should not do polypectomy. Carcinoma shows invasive potential, so we have to get enough submucosal layer tissue, so EMR is important. If we conducted polypectomy, cutting edge is like this and deep margin positive. Next. This is NBI magnifying view. Please vote. Show me result. Oh, great. This is typical JNet type 3, disrupted vessel and scattering vessel and amorphous surface pattern. Unfortunately, this is insular mucosal carcinoma, but accompanied by moderate dysplasia. Sometimes, even for insular mucosal carcinoma, lesion shows desmoplasia and invasive growth. Anyway, this is typical JNet type 3. How about this? This is NBI magnifying view. Please vote. Show me result. To be type 3. More difficult. You can see surface pit-like structure, irregular pit-like structure. Vessel pattern is microvascular area and scattering vessel, but these pit-like pattern exist, but irregular, so JNet type 2B. This is also SM invasive carcinoma at that point. Type 5, case 5. This is very tiny polyp. This is NBI magnifying view. Please vote. Please vote. Show me result. Great. Correct answer is type 2B. There is irregular pit-like structure. Over diagnosis is dangerous because over surgery will be conducted. So anyway, this is very tiny lesion. We conducted EMR. This is also SM invasive carcinoma. JNet type 2B, JNet type 3, please pay attention to treatment selection. Case 6. This is polypoid lesion, 1.5 millimeter in diameter. This is NBI magnifying view. Please vote. To A or to B or type 3. Please show me result. Please vote. JNet type 2A and JNet type 2B, half and half. Correct answer is JNet type 2B, because margin of pit is not smooth. This irregular pit pattern and this region show SM deep invasion. Please compare. This is the image of this region. This is the image previously I showed you as a typical JNet type 2A classification. Please compare pit-like structure margin. Pit-like structure margin is very smooth. On the other hand, this region shows very irregular. To understand This difference is very, very important in daily clinical practice. Please take care. Last case. This is 2A plus 2C, so-called LSD non-granular type pseudodepression. This is NBI magnifying view. This part, this white part. Please diagnose, please vote. Okay. Correct answer is JNet type 3. Vessels are disrupted and this area is amorphous. So this is typical JNet type 3. So we sent this patient to surgery. At this part, lesion shows SM deep invasion, like this. By the way, today I will give a lecture on JNet classification using NBI magnification. He's Naoshita Yoshida, my friend in Kyoto Prefectural University. He proves NBI and BLI shows same diagnostic ability. He used Hiroshima classification. Using Hiroshima classification, he proved same diagnostic ability of BLI and NBI. JNet classification was established by NBI magnification. However, I know Fujino is very popular in Brazil. BLI can apply. BLI can be used for JNet classification diagnosis. I will show example. This is JNet type 2A lesion. This is NBI magnifying view. This is BLI magnifying view. You can get almost same findings. This is JNet type 2B lesion. This is NBI magnifying view. This is BLI magnifying view. You can see almost same findings. Like this, even in Brazil, you can use JNet classification effectively using BLI. Of course, NBI is okay. This atlas was published by Professor Tajiri, Professor Kato, me, and Yutaka Saito, and Muto Manabu. This atlas contains NBI, BLI from upper GI to colon and rectum. If you are interested, please vote and learn this atlas. Your diagnostic skill will definitely improve. Thank you for your attention. That's all. Thank you.
Sensei,
Yes.
I have sent you a few questions.
Okay.
Thank you very much for the presentation. It was extremely interesting, wonderful presentation, and I have sent you a few questions from a few guests. Could you answer them now?
Okay.
Yes.
I can't hear nothing.
Yes, sir. They will ask you now. Okay, so good evening, everyone. Once again, thanking. Good afternoon to a few, good morning to others, especially to Professor Tanaka. Good morning. It's a real great pleasure to be here moderating this webinar together with Dr. Rodrigo and Dr. Eduardo Moraes. A special thanks to Dr. Tanaka, who has presented this brilliant presentation. We admire and we learn with your images, which are just spectacular. And with it's so interesting to bring the most updated technique in colonoscopy of high quality. We thank Itaigara Memorial Hospital for having given us the opportunity to be here with you, sir. Thank you for contributing and also share with everyone and interact with you through questions was the best technique that we have in oncologic endoscopy. We are always surprised by the diversity of questions that we received as we have received in our chat. We have a good number of online participants and will promote the statistics, but these are surprising numbers because of the number of people who are participating in this live. We remind you that we are following the recommendations of social distancing from the Ministry of Health and WHO, which this webinar is respecting fully. It's always important to remind you, as Dr. Tanaka has reminded us, it's still a very concerning moment, and we are very much concerned about the pandemics. Please send questions. The question that will not be able to answer, will give you the answers later, but we are here online ready. One of the questions that we have received concerns the increment, the gain of electronic chromoscopy and magnification in the analysis of these images. Is it mandatory to have chromoscopy and magnification to be able to use JNET classification? Is it mandatory to have magnification to use JNET classification? Is that okay? Yeah.
Nowadays, magnification is essential for colorectal colonoscopic examination, because without chromo agent such as indigo carmine, we can easily distinguish between non-neoplasia and adenoma and benign adenoma and carcinoma. So also to determine the therapeutic strategy, if lesion is carcinoma, we should do EMR, not polypectomy. If carcinoma, we have to detect en bloc, so EMR or ESD. But benign adenoma can be treated by piecemeal EMR. Like this, magnification is becoming essential. Soon, in Japan, maybe all over the world, Olympus company will release new version of endoscopy system, next of Lucera Elite. This system shows almost autofocus magnifying function. So In addition to this launching of new modality, NBI and bit pattern magnification will spread all over the world. Please don't be late against all over the world in Brazilian endoscopists.
Continuing with the questions.
As far as I know, Brazil is the second company all over the world. Magnification is popular next to Japan.
Now, continuing with the questions, we know that the possibility of serrated lesions every time we give advanced neoplasia diagnosis, and we have also the detection of serrated lesion that is low. What is the gain in your classification and high quality colonoscopy in the detection of serrated lesions? Is it clear, sir?
Today, I omit the explanation of serrated lesion. Basically, serrated lesion is classified in genetic type 1. When we diagnose genetic type 1, we have to distinguish between serrated neoplasia or hyperplasia using pit pattern. As you know, large opened large various type of stellar pit is typical for SSL. Also, if accompanied by cytological dysplasia, you can detect genetic type 2A or 2B. And there are no enough evidence. Now in Japan, we detect SSAP if size is larger than 1 centimeter. Also, mucus, existence of mucus is a good indicator for SSAP. Standard view is also useful. But in magnifying view, various type of stellar shape pit is indicator for SSAP.
Sensei, we have a question from Professor Nelson Miyajima. In rectal lesions, the criteria for a cure could be extended to more than 1,000 micra if there are no other risk factors.
2,000 millimeter. 2,000
millimeters?
In Japanese, from Japanese evidence, even if deep invasive submucosal carcinoma, if there are no other lymph node metastatic risk factors such as vessel involvement, high-grade budding, and unfavorable histology, only risk factor is SM deep. Statistical lymph node metastatic risk is 1.2 to 1.4%. So, considering the patient situation, age, and comorbid disease, and body activity, also his own will, we decide the therapeutic strategy with both patients and us.
Professor Tanaka, still about this patient with a rectal lesion with a deep involvement of 2000 micra. Would you always offer surgery, or in some cases, would you offer complementary treatment like chemo and radiotherapy?
In such a case, I tell the patient the fact of lymph node metastatic risk of percentage. Decision should be made by patient himself. Of course, we explain the complication after surgery, sexual dysfunction, incontinence. Miyajima sensei, if the lesion located in your lower rectum, how will you do? After
Usually the same thing. The decision is shared with the patient, and indication is surgery, amputation. Sometimes if the patient does not want amputation, depending on the risk, we should have clinical observation. In selected cases of a lymph node involvement, we could discuss a chemo and radiotherapy, but once again, only when the patient refuses surgery that is considered as the standard treatment.
Now in Japan, radiochemotherapy after endoscopic resection for SM deep invasive carcinoma is ongoing. This study is ongoing.
A question that I had was concerning chemoradiotherapy for an invasive tumor with the purpose of preserving the rectum. An evaluation with NBI could help us identify the response to treatment of the complete response to treatment, do you think?
No. Local residue can be diagnosed by standard endoscopy. Maybe EUS is more important.
A question from Dr. Rox Sanchez from Santiago. Artificial intelligence using chromoendoscopy works for diagnosis and to decide between resection or leave the lesion as a strategy. Do you think that we could use artificial intelligence for regions with difficulty in access to techniques?
Yeah, now AI is remarkably developing. Soon we can use in clinical daily practice. Maybe IEE magnification will contribute to distinguish between neoplasia and non-neoplasia. So for reject and discard strategy, IE will contribute. At present, even if endoscopists use NBI magnification, BLI magnification, IE, not so good accuracy is obtained to conduct reject and discard strategy. Reject and discard strategy is now distant purpose, not practical.
A question from Daniela. A question from Daniela from Goiânia regarding NBI technology to improve endoscopy and characterize the colon cancer. What should be good for the Brazilian reality? JNet? For the Brazilian reality, do you think that JNet would be suitable?
Yeah, of course. JNet is very simple. I recommend at first, please use nice classification. Nice classification, maybe as you know, nice classification can detect non-neoplasia and deep invasive carcinoma. After mastering the nice classification, please use JNet classification. JNet classification needs magnification. Without magnification, you cannot distinguish between type 2A and type 2B. JNet classification should be spread all over the world, I believe.
Last question. Vito is going to ask it. Dr. Tanaka, we have many people from all places in the world following us. And we have great return congratulating you on this brilliant presentation and for the many different cases that you have presented. And this makes us very happy to be together with you here in this live presentation. There is a question, a personal question I'd like to ask you regarding your idea for Brazil, which is a country with a diversity. We have good techniques in large centers, but Brazil is a continental country, a very, very big country. And we have many regions in Brazil with no access to chromoscopy and many times not even magnification. What are the advices you would give us for a high quality colonoscopy in places with few resources, especially because they have no economic resources with a good distribution as you have in Japan? What would be your advice for Brazil?
Difficult question. At first, please have many conference, not only special lecture of paper review or explanation of principle, but concrete, detailed case discussion like in this webinar. This is very important. Then everyone may be interested in detailed examination. Then necessity will cause in Brazil. Next, as far as I know, Olympus endoscopy is more expensive than Fujinon one. Maybe Fujinon scope is cheaper than Olympus. If any endoscope, if it accompanied by magnifying function, you can observe microstructure. Please try. At first, have an interest in detailed examination. If so, society will adjust to necessity. Even if there is a good modality, if everyone are not interested in detailed examination, everyone will not use. This is same in Japan. A few years ago, Japan is also so. Do you understand my English?
Yes, sir. So to close, Professor Tanaka, thank you so much for the lesson, for having allowed us to participate in your daily activities so bad once again, and the president of our society, and Ricardo Gibi, CIED, and its president, Azadu. Thank you. We are closing this session, and we thank you so much for your presence.
Thank you so much. Please take care and do safe for COVID-19.
Thank you, sir.
Thank you.